You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant.
At the nexus of academics and research, medicine and healthcare, and economic development is the Pittsburgh firm of Tripp Umbach, a consulting firm able to assess and advise on the needs for everything from additional opportunities to train more physicians in new and sometimes different ways to the economic impact of intercollegiate athletics. We're very happy to have with us on Innovators today Paul Umbach. He is the founder and senior principal of Tripp Umbach. Paul is a graduate of Harvard, the University of Akron, and Concordia College, and we all came to the conclusion that any person able to live with the tensions of keen interest in English literature, advanced management development, and geography and regional planning is certainly capable of advising on a wealth of topics. Welcome to Innovators, Paul.
Great. Thanks, Rick. It's good to be joining you. I also studied to be a Lutheran minister and went to college on a cello performance scholarship. So I like lots of different things. And some, I call myself a geographer, which I guess is the
That's even more.
kind of the, well, it kind of encompasses so many of the interests about space and about place and people and society. Yep. So.
Well, we're glad to have you because it sounds as if we've discovered a Renaissance man in a time that we desperately need them. Let me begin by noting something. Back in 2015, we wrote an article for University Business, and we said that at the time, academic medicine was probably the main growth sector of American higher education, with more than a score of new allopathic and osteopathic medical schools launched and still more to come. What are the forces that are propelling the growth in this whole field of academic health in medical centers? What really are the drivers?
Well, I think there are two principal drivers. We've been involved with 30 new or expanded medical schools in the last 15 years, and there's two things driving it. The first thing is demographics themselves. There's over 325 million people now in the country. When I went to college, we were at about 260 million, and my professors would tell me, we'll never get to 300 million. We're going to be just like France and Germany and England. We're going to flatline. Somehow 150 million more people joined the country. They're also older. There's more chronic disease. So just the fact that the demand for healthcare has grown faster than the supply. And it's not just for doctors, it's for every kind of health professional. The second thing that's happening at the same time is this tremendous transformation in health and healthcare and the need to train a whole new workforce that's more directed toward healthcare today and especially healthcare in the future. So we're retraining, plus we need more people in the first place. So there's two of these forces happening at the same time. And Buzz Cooper, a really great guy who is very well known, he passed away 2 summers ago. He was my first senior consultant at Tripp Umbach. He said, we will never have enough healthcare practitioners, no matter how hard we try, because we miss the chance to catch up with the amount of growth in our population and aging. So that's a big part of it right there.
Yeah, and yesterday, I think it was yesterday, AAMC, the Association of American Medical Colleges, put out their estimate of the shortage of physicians in there. They're talking now about more than 151,000 new doctors being needed. So that confirms at least one part of what you said. Well, let's stay on medicine for a minute in healthcare. There's a book that was written by a father-son combination, Richard and Daniel Susskind. It's been an important book in many ways. It's called The Future of the Professions, How Technology Will Transform the Work of Human Experts. And there's a section in there where they quote the cardiologist Eric Topol. And when he says, we're embarking on a time when each individual will have their own medical data and the computing power to process it, from womb to tomb, even to prevent an illness before it happens. Now, This sort of relationship between an individual and a physician is summed up by Topol's title for his book, The Patient Will See You Now. Now, Tripp Umbach is known for, among lots of things, assessing the impact of academic health centers and estimating healthcare needs. How will technology, which we've always assumed was going to somehow transform things and improve things, how will technology affect the importance of medical centers, in particular, the physical requirements for delivering care, whether that's a hospital or whatever?
Well, we're already seeing tremendous changes in this. When I began Tripp Umbach almost 30 years ago, hospitals were way, way larger, and there was way more development of the physical plant. So we can just look at the physical requirements of delivering healthcare and the settings. They've changed dramatically.
Yes.
We're now looking at teaching hospitals and very high-end medical centers being about a third as big as they were back in the old days. We're seeing that the hospitals of the future have much more technology, and the patients are, of course, staying a lot shorter in distance, and they're not warehouses anymore for chronically ill patients that stay for days and days. So we're already seeing that change. But I think the biggest change, and what Topol and others have talked about, is the role of the patient. So at the intersection of economics and health, and let's throw in healthcare and education, you have a patient now that's entirely different. So maybe 20 years ago, there was this new thing called patient-centered care.
Right.
Now we've moved pretty quickly to patient-directed care. And the thing that's so fascinating to me is it's it's not in many ways different than 100 years ago or 200 years ago, when you were pretty much in charge of your health and you had to direct your own health. And doctors back then were more like contractors and folks that you'd call up to help you when you were in a bad state, but they weren't folks that you entirely relied on for your health and health care. So we're kind of going to today, we're like we were when 100 years ago, if you weren't keeping yourself healthy and managing your health, you'd be dead. Somehow in the 1950s, 60s, 70s, and 80s, we got this false notion that we could have the healthcare system fix us, manage us, cure us, and be focused on us. But we found that system doesn't do well at being focused on us. We have to be focused on us. And now we enter a technology era where we have so many more tools at our disposal, things we never had before in the modern healthcare era, that we can now start to say, wait a minute, I can make a good decision. I might consult with a physician or two, but I know what I really think I need to do. And that's changing everything. And it's even changing, back to the first topic, how we teach medical students. Medical students are now taught to be a team with their patient and not to be, in a sense, the gods of the system telling the patient what to do. And it's going to be, and this is going to take 50 years to finally work itself completely out. People not born yet, who will be born soon, will have their whole life as individual champions of their health and their health care. And people still alive today over 55, people my age and older, will still live in this era where the doctor knows best and they'll follow and they won't need the technology or care much about the technology that's at their fingerprints. And so that's a big change that we're witnessing. And it's even going back into the new medical school curriculum to be aware of this for doctors and healthcare professionals.
Well, that's fascinating, because it leads to another issue that crops up when we do work in medical and healthcare. Medical schools have always depended, at least the traditional notion of medical schools have long depended on having pretty easy access to hospitals and clinics, because those served as the sites for training health professionals. In fact, until about 30 or more years ago, hospital and clinics were usually actually part of the same university to which medical schools belonged. And today, hospitals are more often than not legally and financially independent of universities, and medical schools and the other health professions have to negotiate for access to those facilities. So if you think, as you just described there, about what's going to happen when we change the nature of the clinical setting so profoundly as you've described now, what is that going to mean for medical schools and other entities that prepare healthcare professionals? What's that going to mean about their relationship to where care is actually delivered?
Well, we've already seen, if you look at the last 15 medical schools in America, I think all of those 15 and maybe the 15 that are in the accreditation process, so that's 30 projects. All of our projects do not have an integrated hospital and academic medical center framework. The medical schools that have been developed in the last 15 years are all community-based, which means they send their students not just to a variety of hospitals, but they send their students to physician offices, community health centers, federally qualified health centers, and more they're sending their students into the community themselves. And some medical schools like FIU in Florida has a nationally known program that sends their students into homes of people, like door to door. A group of students of different kinds and different disciplines will come in. So what does this really mean? It means that medical education follows healthcare. It doesn't lead healthcare. So what does that mean? That means that over time, medical education, from the time it began in the 1800s and even before then, was the relevant way of training a doctor for that time and place. So it's okay that, in fact, I would argue it's much better from a population health perspective and a community health perspective that the physicians spend less and less of their time in the traditional hospital setting, making rounds. I mean, there were times maybe 20, 30 years ago that a physician really only saw a patient in their entire training in a hospital bed setting. And yet then they'd go and practice in offices and in clinics and in communities where all the patients they saw weren't in the hospital. Now it's lining up a lot better. We now have students that spend the majority of their time training for their practice in a community setting, much like the setting they're going to practice in. And now we're going to have another leap. The next leap is a world with very little hospital care and a ton of community population wellness and care because of something that we'll talk about, and we can talk more about it whenever you want to, and that is called economic design. The economic design of health changes everything, because now if the payments come in part from keeping people healthier and not utilizing services, we now don't want to have them in expensive hospital settings, and the physician will have to get more used to managing and directing and improving and coaching people on their health than diagnosing and treating their disease and their illness. Changes everything in terms of the training model. Yes, everything changes when economics change.
Paul, that's an interesting. Just this past week, I went in to see my doctor, and she brought up the fact that since I'm a little bit older than 65, she said, have you tried the new shingles vaccine? I said, well, I got that years ago. She said, no, there's a new one. It's been approved by FDA, and CDC is proposing that it really be the one drug of use. That vaccine cost over $250. The insurance company, my insurance company, gladly paid it, because they would much rather pay me to avoid shingles than to pay the cost of dealing with shingles in my case. Is that part of this economics design? You've now given a prime example of economic design. What economic design is, in a nutshell, it's amortizing the cost savings in the future and saying, okay, that's worth something. You would have spent $20,000 and now you're only paying $200, and bringing that money back to now and making that investment in health. The model that we had with DRGs and before DRGs, with the huge change in economics in the 50s and 60s when government started paying for health care, Mm-hmm.
The model shifted to how much volume can we do? How much can we make
Mm-hmm.
from people needing healthcare? And that changed everything. Now we went from, 500 billion in healthcare spending, and now we're at 3 point something trillion in just my lifetime. So in my lifetime, in 50 years, we went from a very small amount, and we were about average in the world in healthcare spending, to now the healthcare economy would be the 5th largest economy on earth. Just healthcare in America would be the world's 5th largest economy. So if you think about it that way, the money and the economic model drove what we have. Now in this next model, we're even going to go further, and we're going to start having medical schools. Our first medical schools now are just beginning to have a new model that instead of getting their revenue from faculty practice, which is really a surcharge on care. And it's something that they call the dean's tax. They give like 5% of the money to the dean to run the medical school on volume. But now we're going to have the first medical schools, I'm working on several, where their money is going to come from a percentage of the health cost savings. So if they're working in a community, and a big county or a big payer or a big system is saving $50 million a year because of what the medical school is doing, they'll give 10 million of that, let's say, to the medical school out of the 50 million in savings. That's going to change the economic model of medical schools and force the medical schools, their researchers, their students, and their practice and curriculum to be more about health and the health of people than disease treatment and volume. How many tests can I run? How much can we spend on this patient? Let's please keep this patient alive longer, because if we do that, we'll give more money, versus palliative care and other kinds of processes to lower the cost of healthcare in the final months of life.
So, Paul, would it be safe to say, looping back to what you talked about earlier, that medical schools will have to not only embody this change, but doctors, the notion of where they will deliver care could change completely. Much of it will be in all sorts of environments, including a technologically based way of doing it.
I see technology and home coming together. I had a client one time that coined it's the marriage of Watson and Rockwell. The Norman Rockwell and the IBM Watson coming together. And so what you'd have is high tech, and then when you really need to have an encounter with this person called the physician or team leader, it could be at your home that they make a visit. Now we've harkened back to Rockwell, and we've harkened back to the beginning of the doctor with the black bag, but there's a lot of technology in that bag. And then on the other hand, we'll also have physicians in population health models really kind of being team leaders. And I'm a geographer, so I could see the future of healthcare being this one doctor has 5 square miles in this city, and that doctor is responsible for working with all the healthcare professionals in that 5 square miles to provide the services that the people need to stay healthy. And yes, there's a hospital in that 5 square miles. Of course there is, because there was a time when someone needs a very intensive high-tech surgery or diagnostic treatment. But really, the majority of people won't be going to an emergency room. The emergency room, in a sense, is coming to them. So we're seeing this already happening. It's not right away, because emergency room visitation is at an all-time high. But over time, we're going to see that lower.
That's fascinating to even contemplate right now. And I hope that you will commission a portrait in the Rockwell style of delivering care of Watson. That we need that painting commissioned at some point.
Yeah.
That sounds like a lot of change. That's an enormous amount of change in a sector that has been almost in whitewater for the last 30 to 40 years. So let me talk a little bit about leadership, because while it comes in all shapes and sizes, your firm, the work you do, is right at that convergence of institutions about which it's often said everybody's responsible, but nobody's in charge. So the surgeons perform their magic surgically, more or less as autonomous actors. And faculty members, professors, teach and research what interests them most. And sometimes they pay, but not a lot of attention to what the degree curriculum requirements are. So in a highly decentralized system like that, what's the nature of leadership? What are the attributes of people who are likely to be or may be successful leaders in a setting that's just profoundly changing?
Well, we're seeing a lot of change. Very good question. We're seeing a lot of change in when I started in the late 80s as a consultant, healthcare was largely a cottage industry. Every town had one or two hospitals, generally a Catholic one and a non-Catholic one. And they were both nonprofit, and there was a physician complement that worked at that hospital, but they were very decentralized from other large physician groups or practices. They were solo practitioners or in small groups, and pretty much every town in America had its own healthcare economy around its own hospital or hospitals, and even larger cities. Pittsburgh, where I spent my whole career, had 5 very big, nice hospitals, but they weren't connected until the early 1990s and mid-1990s when UPMC was developed, and we saw that in Boston with partners, and we saw that around the country. And we also saw some large physician practices like Geisinger, Mayo, Cleveland Clinic that actually morphed into systems. So what we now have is probably 50 health systems that in the next 10 to 20 years will be the 50 places where there's some leadership and coordination. And one of the reasons for this is this economic design shift.
Exactly.
In a model where everybody can bill as much as they can and collect as much as they can, you can have 3,000 different micro healthcare cottage industries happening in every town in America. But if you're looking for efficiencies and cost savings, and if you're looking for coordinating and honing all this into some very directed policies and very directed processes, well, that's where you have these. Now you're seeing about 50 health systems emerge that will become, now, is that good or bad? Well, you can argue that, well, where's government in there? Some people on one side of the political equation would say, that seems really scary. It looks like 50 monopolies. On the other hand, you might argue, well, if the incentives are to lower costs and improve health, who cares who does that, be it the government, like in some cultures, the private sector in other cultures. And so Tripp Umbach has lived at that intersection of health, healthcare, and economics since we began. And we're probably the only company that really saw that as a place to be in. And we were fortunate to be at that place because we had very diverse projects. We had economic impact studies that were miles away at one point in our portfolio from the community health projects. And then we had miles away, we had these things called academic medical centers that seemed totally different than health and economics. And then all of a sudden we woke up about 3 or 4 years ago and said, all of our things are right here in the middle. And that's where the action has been.
Gotcha. Let me follow up, because you mentioned something that I think is critical to understanding not only your work, but the way in which change is coming about. Not too many years ago, Pittsburgh was seen as a fading city. Instead, now it's an urban center where the presence of several world-class universities and fine colleges, a whole bunch of, especially one, University of Pittsburgh Medical Center and the like, came together, and in many ways they have spawned this renaissance downtown. If you go to Houston, Texas, they'll tell you that in a 2 square mile area, which is home to over 50 medical institutions, and they describe that area as the space that's the largest complex of hospitals and medical research facilities in the world. Now, in both of those cases, Pittsburgh and Houston, medical schools, universities, healthcare facilities seem to be sort of core elements of much larger development that extends to hotels, restaurants, professional services, you name it. Now, Given the complexity of such undertakings, because I appreciate the way you described it as miles apart, they moved closer, but given the complexity of that, who hires you to do this work? I mean, does anybody stand up and raise their hand and say, Tripp Umbach, we want you to come kind of explain what we're doing? Or is it the case where bits and pieces, various entities bring you in? How do you actually get hired when you're working with so many relatively autonomous, complex institutions?
Well, that's a great question. That's our whole life. Every day every day at Tripp Umbach, we get one really good lead from somewhere in the world to work, and about twice a week we start a new assignment. So we're very busy, and we run through about 100 assignments a year. And one of the things we'll talk about the doors that they go through. There's three doors. The one door, which used to be the main door, would be the universities that would hire us to say, we'd like to do a medical school. Can you come to our university? And the second door might be a healthcare system or a payer like a Blue Cross Blue Shield. And they would say, we'd really want you to come and work for our hospital system. We're thinking about doing what Pittsburgh's done. And it's been great that we've had our company in Pittsburgh all along, because we've been in probably the best example of renaissance and economic development around eds and meds. And it's such a dynamic, incredible story. And we're part of that story because we actually were the consulting firm that pulled UPMC together. That was one of our first projects. So we get to say that we were the consulting firm on day one of the largest integrated health systems in the world. But now, more and more, Rick, we're getting the communities calling us: Spokane, Evansville, Saginaw, communities like Charlotte. I'm getting more calls from economic development folks and folks that want to drive their economy. Now, when we go through any of these doors, we instantly at meeting one meet all the people from all the other doors. So what's great about these projects is it's not like I never see my medical school friends or my health system or my payer or my community health friends. I see all of the friends, but we're coming in through a community economic development door. And if you look at some of our most recent projects, it was the folks in, even our first medical school was not a university or a hospital system or a payer or government. It was community leaders in Scranton that said, we'd like to have a medical school to really grow our region. And the only reason we won that project was there was 2 interviews before us and then us. And then they called and said, well, we're not going to have you interview until noon because we have 3 firms now, and they're all big national firms. They're not small potatoes like little old Tripp Umbach. I mean, if you want to come at lunch because you're from Pennsylvania, drive in and during lunch, you can we'll listen to you, but we're going to pick from these 3 large firms. And I always joke that the 3 firms were Deloitte, and Deloitte. And the reality was, when I finally got to talk, Dr. Wright at the time, who was the founder of that medical school and the leader in the community, said, don't do your PowerPoint. We just have one question for you. Do you think that Scranton can have a medical school? And I said, yes, I do. And he said, stop right there. He said, 3 firms this morning just told us we are crazy and it can't be done. Okay, so sometimes I think our attitude about what we think can happen and our attitude to try and make it happen from a economic development perspective and a geography perspective has sometimes trumped the fact that did we really know that Commonwealth, which is now owned and operated by Geisinger, did we really know that could be, and the Geisinger Medical School could really be? Well, I probably didn't know that, but I had a belief that a community that wanted something can get something. And I think that's everything.
I can't tell you how much I've learned from this, and how much I'm fairly certain many of the people who'll be listening to this will come away as I have, feeling like they've been able to really grasp a lot more than was the case before listening to you. Thank you very much for your time.
Thank you very much, Rick.
Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.